Hello, morning.
Hello. How are you?
I'm fine, and you?
Good. I don't think we've talked. I'm Adam. I'm one of the chairs of the Pain Research Forum that helps run these things. Um, so
I
yeah.
I can I test my screen share?
Yeah. Yep. And your audio sounds good. Do you have access to screen share or do I need to give it to you?
Okay. For me, is visible?
I don't see it.
Uh,
Do I need to give you access to screen share? Who's tools for share? Ah, here we go. Okay. Do you see it now?
mm. Okay.
There you go. Ooh.
It's okay.
Yep, looks great.
Uh, tá. Okay.
Great. So I'll start off the um uh I'll like launch the meeting right at 10. Maybe give like a minute for people to kind of filter in. There's already 7 people in, so that's great. In the waiting room.
Okay.
Um, and then I've got just the poster slide. And so it can welcome everyone and introduce you as the presenter, and then I'll just hand it over to you and you can share and get started.
Okay. My name is Rhayane Monteiro, and I am a PhD student in dentistry uh, with a concentration oral physiology at the Piracicaba Dental School, University of Campinas in Brazil.
Oh, great.
I I research in pain human mechanisms.
Hmm.
Um, that's it.
So your name, Ryan Monteiro, is that right, Ryan?
Repeat, please.
Am I pronouncing your name correctly, Ryan?
Ryan Monteiro.
Ryan Montero.
Yeah.
Close enough. Sorry. Um, So yeah, I'll just we still have 5 minutes before I'll let other people in.
Okay.
Um, and so yeah. So we'll just start it then and I'll have the slide sharing and just go through kind of how this works is you'll present and I'll encourage people to ask questions. I found this really works really well when people interact. It's a lot more fun that way.
Yeah.
So we'll see if we get people asking questions and stuff. But
Okay.
it's really quick. Let's just turn on my door. It's okay. Thanks for doing this. I'm excited.
Thank you.
Mhm. Arrow, my visual pain. Great. Go ahead and share my screen so I'm set up on my end. Look good to you?
Yeah.
Great. Just give it a few more minutes.
Okay.
People are trickling in though, so that's good. Already got 12 people in the room waiting to go. Yay. That's great. All right, I have it as 10 o'clock, so I'll admit everyone and then give it another maybe minute, and then I'll do the introduction slide and then hand it over to you. Sound good?
Okay.
All right. All right. Welcome, everyone. I think we can go ahead and get started. My name is Adam Dorson. I am part of Pain Research Forum and excited to be here for today's Journal Club. This is our Pain Research Forum Journal Club series. It's out the IASP, and it's a special interest groups of IASP. So today is orofacial and head pain. And really excited for today. We have Rhayane Monteiro to present this fantastic and hopefully encourage some lively discussion between you all in the room and us as we go through this paper. So with that, I'll go ahead and stop my sharing, and Ryan, you can take over.
Okay. Can you see my screen?
Yes, looks great.
Can I start?
Yep, thank you.
Okay. Hi, everyone. My name is Rhayane Monteiro, and I am a PhD student in dentistry with a concentration in oral physiology at the Piracicaba Dental School, University of Campinas. And it's a pleasure to participate in today's Journal Club. The paper I will be presented today is entitled Myofascial Pain with Referral, Role of Nociceptive Drive in Central Pain Mechanisms by Zebda and colleagues, published this year. If you would like to read the paper, you can access it by scanning the QR code displayed on this slide. Before we begin, I would like to disclose that I have no conflicts of interest related to this study. Today's presentation is organized according to the main sections of the paper: introduction, methods, results, and discussion. To start, I'd like to pose the following question. When a patient with temporomandibular disorders presents with referred pain, are we observing a phenomenon predominantly driven by persistent peripheral nociceptive input or by alterations in central pain processing? To address this question, let's first define the referred pain. Referred pain is defined as pain perceived in an area distant from the actual site of nociception. It is typically described as diffuse, dull, aching pain that spreads over a wide area with a vein boundary. Referred pain is challenging for both patients and clinicians, as it is seldom reported in the chief complaint. In temporomandibular disorders, referred pain is a common occurrence with reported prevalence likely averaging around half of individuals diagnosed with painful TMD. The specific area of the muscle or fascia considered to be the presumed nociceptive source of referred pain appears to be associated with localized increases in algogenic substances, as well as increased muscle activity within the affected tissue. For example, Shah and colleagues demonstrated through microdialysis that the tissue acting as the source of referred pain exhibited reduced pH and elevated levels of substance P. They also identified increased concentrations of several inflammatory mediators, including bradykinin, calcitonin, gene-related peptides, and the pro-inflammatory cytokines, interleukin-6 and 8, within active myofascial trigger points. Similarly, Shirk and colleagues observed increased action potential activity recorded using monopolar needle electrodes surrounding a discrete focus within the tissue identified as the source of referred pain. The study investigated the effect of increased sympathetic activity induced by elevated intrathoracic pressure on the electrical activity of painful muscle tissue. In addition, Fernando de la Penas and colleagues demonstrated that dry needling applied directly to the presumed source of referred pain reduces peripheral nociceptive inputs and helps normalize muscle function. These findings support the existence of a peripheral generator of referred pain and are consistent with the evidence obtained from both microdialysis and electrophysiological studies. Although several local tissue alterations have been identified at the presumed nociceptive source of referred pain, the mechanisms underlying this phenomenon remain an active area of investigation and, in some respects, remain controversial. Current evidence suggests that peripheral neural pathways and shared neural networks play complex roles in the transmission of referred pain. However, no single mechanism has been fully established. The currently dominant theories include the convergence of afferent fibers from different tissues onto common spinal neurons, the bifurcation of nociceptive input from different tissue, and the axon reflex theory. Collectively, these models primarily explain referred pain as a consequence of persistent peripheral nociceptive input. However, referred pain arising from myofascial tissues has also been associated with central pain mechanisms. The central hyperexcitability theory suggests that the dorsal horn neurons in the spinal cord become sensitized, activating previous inactive external connections and leading to perception of pain in areas distant from the actual source. Likewise, both the neurometric theory and nociplastic pain proposal emphasize the role of higher pain processing centers beyond the only nociceptive inputs, and which fundamentally contribute to chronic painful conditions and widespread pain, in addition to referred pain. Importantly, these theories highlight how referred pain occurs in the absence of peripheral tissue damage or lesions. Overall, the available evidence supports the plausibility of two major contributors to referred pain: nociceptive drive and central pain process. Both appear to be important contributors. However, in the absence of some form of observable tissue damage, central pain process would seem to be a more plausible explanation and pointed to a central-based explanation underlying particular success wrongly attributed to the peripheral treatment. With this background, this study aimed to explore the contribution of nociceptive drive and central pain process. Based on select proxy variables to the report of referred pain as determined by clinical examination provocation. To address this question, the authors used a cross-sectional observational dataset from the TMJ Impact Project, a collaborative effort between the University of Minnesota, the University of Washington, and the University at Buffalo. The TMJ Impact Project enrolled 401 participants who fulfilled diagnostic criteria as either TMJ cases or controls. The study followed the workflow below. Participants were initially screened by telephone to determine study eligibility. A set of self-report questionnaires was mailed to eligible participants and completed before the clinical visit. During a single study visit, participants completed the informed consent process, self-report questionnaires, a clinical examination, and cone-beam computed tomography imaging. All clinical assessments were performed by calibrated examiners. Clinical assessment consisted of a CTMD compliant examination. Standardized pain palpation was performed using a 1 kilogram force applied for 5 seconds over the mastigatory muscles and TMJs. Muscle palpation followed a standardized zone-bend sampling approach based on the CTMD protocol. This approach focused on broad pairs on ongoing peripheral tissue process rather than identified isolated lesions or trigger points. When pain was elicited during palpation, participants were asked whether it remained localized to the palpation sites or extended beyond the palpated structure. Although the CTMD classifies muscle pain as myalgia, local pain, or myofascial pain with referral, the authors also evaluated referred pain elicited by TMJ palpation and incorporated it into the study classification algorithm. Pain extending beyond the palpated structure was classified as referred pain, otherwise it was classified as local pain. Thus, the final analytical sample included 118 participants with referred pain and 175 participants with local pain only, with the latter serving as the reference group. Based on the available assessment instruments, the authors selected predictor variables reflecting underlying process were selected based on the face validity. These variables were organized into two domains: the nociceptive drive domain and the central pain processing domain. Because no direct measures exist for these domains, nociceptive drive and central pain process were conceptualized as theoretical constructs. To represent nociceptive drive, the authors select variables reflect ongoing nociceptive input originating from the mastigatory system. These variables capture the different manifestations of peripheral tissue dysfunction, include non-specific orofacial symptoms, jet function, pain-free opening and maximum unassisted opening, mechanical hyperalgesia, partial pain sensitivity, and distribution of pain with the trigeminal region. These variables were not intended to measure nociceptive drive directly. Rather, they served as proxy indicators of a latent construct representing ongoing peripheral nociceptive input. To represent central pain process, the authors select variables reflect psychological factors, somatic symptoms, widespread pain, and generalized pain sensitivity outside the trigeminal system. Similar to the nociceptive drive domain, these variables were not direct measures of central pain process, but rather proxy indicators of underlying layered construct. So, how were these layered variables constructed? The first challenge of this study was that neither of the two biological hypotheses could be measured directly. There is no test that provides a direct measure of nociceptive drive or central pain process. Therefore, the authors had to construct these layered variables using multiple clinical measures. Each of these variables provides only part of the information. None of them fully represents the underlying phenomenon. However, when considered together, they can represent the constructor better than any single variable alone. The authors therefore used a hierarchical approach to construct these layered variables. First, they empirically identified which variables naturally clustered together using exploratory factor analysis. Next, they evaluated the internal consistency of each cluster using Kubrick's alpha. Finally, they tested the proposed theoretical model using confirmatory factor analysis. Only after validating these layered constructs did they include them in the regression models. When analyzed separately, both constructs were associated with referred pain. However, when both were included in the same model, only nociceptive drive remained statistically significant. This suggests that part of the association observed of the central pain process was shared with nociceptive drive. Now, let's move on to the results. Who are the patients with referred pain? So, as we saw early, of the 401 participants initially evaluated, 175 were classified into the local pain group and 118 into the referred pain group. Among these 118 patients with referred pain, 98 were diagnosed with myofascial pain with referral, while 20 received other diagnoses. However, more than half of the patients with referred pain also had TMJ evoked referred pain. An important question is whether the two groups were truly comparable. Demographically, they were very similar in terms of age, sex, race, education, and income, which reduces the likelihood to confound. However, the referred pain group reported high pain intensity. The authors also examined which variables differentiated the two groups. Compared with the local pain group, patients with referred pain presented more orofacial symptoms, reduced pain-free mouth opening, greater hyperalgesia, more the points above the neck, and increased trigeminal sensitivity. They also showed greater psychosocial impairment, along with more pain and mechanical sensitivity beyond the trigeminal region. Overall, referred pain was associated with both peripheral and central alterations compared with local pain.
Hey, Rhayane,
Oi.
a quick question. So the referred pain had overall higher pain intensity.
Okay.
Did they comment on the duration at which the subjects had symptoms? Was it just intensity, or was there any association with duration as well?
It is only higher pain intensity. This comparison with local pain group and it is they equal in age, sex, race, education, and income.
Right. But one might predict just by comparison to say migraine and the referred pain associated with migraine that the sort of number of attacks and intensity of attacks is correlated with the area of referral. That is, more attacks, higher intensity attacks, you get more referral. And so the prediction here might be, by analogy, that if the subjects with referred pain have had the pain for longer, then they might start seeing larger referrals than the local pain group,
Mm-hmm.
in addition to intensity.
I understand. I can continue?
Yeah, if they didn't comment on it, that's fine. I was just wondering whether they did.
Repeat, please. Sorry.
If they didn't comment, that's fine. I was just wondering if they did, if the authors did. I can circle back with Richard Orbach and check.
Okay. The paper mostly demonstrated if you results the group was different in these aspects, only higher pain intensity. I don't know explication better, but I think that's it.
Okay, thanks.
Thank you. This brings us to what I believe is the main contribution of this paper, the authors transformed the 14 clinical variables into just two biologically interpretable layered constructors. When each constructor was analyzed individually, both the nociceptive drive and central pain process relative variables were significantly associated with the presence of referred pain. Moreover, both showed similar odds-ratio estimates in the univariate analysis. However, in the multivariable analysis, when both layered constructors were included simultaneously in the model, nociceptive drive remained a significant predictor of referred pain, whereas the central pain processing constructor was no longer significantly associated with referred pain. So, which mechanism remains associated with referred pain when both are included in the same model? Although both domains are associated with referred pain, nociceptive drive emerged as the primary independent predictor. The paper illustrates these findings with these figures, which show the relationship between each layered constructor and the probability of referred pain. The nociceptive derived constructor showed a clear positive association, indicating a strong peripheral contribution to referred pain. In contrast, the central pain processing constructor showed a nonlinear relationship, suggesting a more complex and limited influence. So, based on these findings, we are now able to answer several important questions. Who are the referred pain patients? How do they differ from local pain patients? Which mechanisms are involved? Can these mechanisms be modeled? Which mechanisms best explains referred pain? In summary, the findings indicate that most of the individual's variables used as indirect indicators or proxies contributed to the presence of referred pain. However, once these observed variables were combined into layered constructors, peripheral mechanisms appeared to play predominant role. Several peripheral mechanisms have been proposed to explain referred pain, including the convergence projection theory, the convergence facilitation theory, and the axon reflex theory. Although these physiological models differ, they all share one central concept. Persistent nociceptive input increases the excitability of the nervous system and promotes referred pain. An important question is, if nociceptive drive was the main predictor of referred pain, does that mean central pain processing is not important? The answer is no. Instead, this study suggests a sequential relationship between these mechanisms. The first step is the presence of persistent peripheral nociceptive input, originally from the mastigatory muscles or the temporomandibular joint. This continuous input acts as a trigger, initiating changes with the central nervous system. Over time, central sensitization develops characterized by increased excitability of neurons involved in pain process. This heightened excitability amplifies pain response, causing previously painful stimuli to be perceived as more painful and promote the expansion of receptive fields, thereby contribute to referred pain. If this process persists, it can sustain and perpetuate pain even when the peripheral contributions decrease. Therefore, peripheral and central mechanisms should not be viewed as competing explanation, but rather as complementary mechanisms. Nociceptive drive may initiate the process, whereas central pain process contributes to its amplification and maintenance. One of the most interesting aspects of this study is the way it interprets the trigger point theory. Traditionally, trigger points have been viewed as muscle lesions responsible for referred pain. However, this concept remains controversial because there is still no consistent evidence that the trigger points represent a distinct anatomical entity. The authors propose a different perspective. Rather than being the cause of referred pain, trigger point may represent the clinical manifestation of increased nociceptive drive in peripheral sensitization. In other words, instead of searching for a specific lesion, we should think of a dynamic physiological process that promotes the development of referred pain. This interpretation also supports the use of zone band sampling technique, which evaluates pain response without relying on the identification of thought bands or muscle nodules. In this view, the focus shifts from the existence of the trigger point itself to underlying physiological process that it may represent. From a clinical perspective, this study reinforces that referred pain should not be managed using one-size-fits-all approach. Although central mechanisms are also involved, nociceptive drive was the main independent predictor of referred pain. This suggests that in many patients, interventions aimed at reducing peripheral nociceptive input, such as patient education, self-management, therapeutic exercise, and modification of parafunctional behaviors, may play a central role in treatment. On the other hand, when there is clear evidence of central sensitization, treatment targeting only peripheral mechanisms may not be sufficient. Therefore, the key message is that treatment should be guided by the predominant pain mechanisms in each individual patient. This story has several important strengths. It is the first study to use latent variables to investigate referred pain. It integrates peripheral and central mechanisms within the same model. It proposes a biologically interpretable model, and it introduces a novel way of storing referred pain. However, the study also has important limitations. How it is a cross-sectional study. Confirmatory factor analysis was performed using the same sample, and the latent constructors were based on clinical proxy measures. I would like to conclude by saying that this paper genuinely caught my attention, not only because of the sophistication of its statistical analysis, but more importantly because of the way the authors attempted to transform abstract concepts such as nociceptive drive and central pain process into measurable layered constructs. To me, this represents an important step toward a mechanism-based understanding of referred pain, rather than one based solely on clinical diagnosis. This paper also raises several interesting questions for me. Does central pain process lose significance because it is truly less important or because it shares a large proportion of its variance with nociceptive driving? And would the results be the same if different biomarkers were used? And do these constructs represent true biological mechanisms, or are they simply statistical groups or clinical variables? Maybe this is, in my opinion, this paper's most important contribution. It does not suggest that referred pain is exclusively peripheral or exclusively central. Instead, it is reinforcing the idea that these mechanisms coexist and interact. What the findings suggest is that in this population, nociceptive drive appears to play the predominant role, whereas central pain processing acts as complementary mechanisms that is at last partially dependent on ongoing peripheral nociceptive input. I also believe that incorporate additional biomarkers could provide an even clearer understanding of the respective contributions of peripheral and central mechanisms. Thank you very much for your attention.
Great, great work, Fran. Beautiful paper and really beautiful slides. That's
Thank
great.
you.
So now we can open up for discussion if anybody has thoughts. I had quite a few questions that I can kind of launch off. Most of them were centered around what biologically might be different between the local pain group and the referred pain group. And if I remember, you showed in the method slides that they also tested the pain thresholds in the palm, like a distal site. Are those different between groups?
Sorry, repeat please the final.
Are the pain thresholds in the palm different between patients that had local pain versus referred pain?
Oh, what's different these
Like
groups?
different, I think it's pressure pain thresholds in the palm, like a distal site from the myofascial pain. Was that different in the group of patients that had just the local pain versus those that had the referred pain? Like, I'm wondering if there's like a widespread difference in the people that have referred pain that might be captured at distal sites.
Mm, I understand in this paper the local pain is only in the palpation and referred pain dissemination in other areas in the face or and in the group is nociceptive drive or central pain process. Uh, the groups differ, for example, widespread pain or uh, points above the neck. That's it.
Okay, so maybe they didn't look.
So Joel Greenspan published on that with temporal summation and pressure. They didn't do the palm; they were doing the fingers, and they
Sure.
reported they didn't differentiate referred versus local in that population, but basically everybody had evidence of what they argued were central sensitization because they had altered temporal summation and processing in the distal.
That's compared to healthy controls,
Yeah.
then?
Yeah.
I'm of course thinking like, is there widespread inflammation in these people that have more widespread pain?
Yeah, so that's an interesting question. They didn't look for that, whether you've got a generalized increase in inflammatory load. It's an interesting possibility. In general, you don't see massive increase. I mean, it's interesting the data you showed, Rhayane, in the beginning of the elevated CGRP and bradykinin. Those are relatively transient increases, though. I mean, you would predict sustained increases would have to be responsible for that kind of effect.
Sure.
So Rhayane, what were you thinking about the additional biological variables and how those might have given different results. What were your thoughts there? You suggested that in your summary slide that if they had collected additional biomarkers, they might have seen something different. What were you thinking there?
Okay. What the biomarkers I used?
Yeah.
Uh,
What different biomarkers might have given a different result, and why do you think that?
in my opinion,
Yeah.
uh, I think, for example, tests used QST or in my research, I use nociceptive blink reflex, for example. I imagine different biomarkers using these tests, for example. I don't know, but I think that is it. And you?
So that you think there was something that they were missing that would have suggested a stronger or sort of a central change? Because they were able to pick up a central change, right? I
Ah,
mean, and it's just whether they could separate the relative contribution of the periphery versus central.
interesting question, but I don't know. I uh, I think this part of this paper, but I don't know the response about it.
So you introduced some data from this on the sympathetic recording. So in an earlier Orbach study, they showed increased sympathetic activity. How do you think that contributes or might contribute to these syndromes? And do you think that's a more generalized phenomena or is localized to the joint and overlying musculature?
I think in this population, this study are more nociceptive, but I I think that can have contributions of the two domains igual the paper most nociceptive drive and pain central pain process.
I was also wondering in the like different biomarkers that they used, I wondered if there's a specific one that kind of like drove the different, like a nociceptive one that seemed to like really powerfully predict a local, and then a central one that seemed to like, because they had like four in each group, or like, do you really need all four, or could you narrow it down to more specifics? But I'm not sure if they talked about that. There's a question in the chat from Crystal, which I'll let you read the beginning of because I cannot. But I think what she's asking there to the end is, how does this paper relate to your research and kind of your thoughts?
In my research in the actual, I study the mechanisms pain in human, and I study about nociceptive drive and central pain processing too, and that's it.
Yeah, go ahead, Daniel.
Hi, Rhayane. My name is Danilo Boada from the University of Mexico. I probably missed something very seriously. We were talking about the trigeminal system, right? How they separate peripheral from central. How they did to separate both.
Sorry, repeat please the final.
We were talking about the trigeminal system, right?
Okay.
So I'm wondering how, on the paper, they separate the peripheral component from the central component.
These separately deleted constructors on the nociceptive drive or pain processing, and for example, these authors separately nociceptive drive the patients with pain above the neck, and the central pain sensitization with patients more psychological symptoms, widespread pain, in these aspects, for example.
I see. That's what I thought I understood. I want your opinion on just how sensical this is. I mean, if you want to separate two things related to a circuit of integration, and you're measuring pain on the mandible, and then you are evaluating pain on your foot, how that makes sense?
I agree for you. I think it's difficult to separate both components in diagnosis, for example. It's an important question too.
Precisely. It is an important question. I mean, they're making a case about a central component versus a peripheral component that to some extent I really don't understand, because they are completely interlinked. I can assume that the nociceptors are actually the trigger, and the amplification of the gain circuit, of the decision-making circuit, is a central circuitry. And then you have this cascade of events that happen centrally. We all know that. Now, but the evaluation and the case is done based on what's more important. It's peripheral, it's central. And based on the approach, I still don't understand. I wanted your opinion on it because you read the manuscript. I haven't. I probably need to. But not knowing the nature of the interaction between different branches of the trigeminal system into a circuit in the brainstem, how different dermatomes can be, the reaction on different dermatomes can be integrated as a central component globally. I mean, it is a extreme simplification of something that we do not have enough information for. Just from the standpoint of the argument, are you familiar with Marshall, Deborah, and Ron Amir ignition theory?
That's more relevant to trigeminal neuralgia, though, right?
Correct, but it's just how it actually works, because I know Ron and I know Marshall was trying to make the case about how different branches of the trigeminal system may interact, and that generate some form of gain on the circuit. Now, they never actually prove any emphatic connection between cells or T-junctions. They make some cases about electrical influences, but it was kind of weak in my opinion, probably because of the entities they were trying to analyze. Now, in terms of referral pain, we do not have actually a model. I know Armin Akopian is working on it, but we do not have a constant model for TMG. That's the reality, at least at biological levels. Now, just in the case of this manuscript, and we are trying to understand, I just think that to make the case about central and peripheral component, at minimum, it must be working on the same dermatome. In the same
well, I mean, it's interesting that you bring up the ignition hypothesis, though, because the argument behind it takes advantage of hinges on the fact that you do see at least some somatotopic organization within the trigeminal ganglia. And
Correct.
So you would predict you might see, a trigger point for a pain attack in the context of trigeminal neuralgia in the same dermatome based on that somatotopic organization.
Right.
And I think in this paper, the TMD paper, all they were doing is trying to extrapolate, potentially over-interpreting, I take your point, that anything sort of outside a more, what might be a given, V1, V2, V3 that was also hypersensitive in these patients would have to be reflective of central change. That doesn't argue, per all the points you're raising, that anything that's localized to, say, V1 or V2 is necessarily peripheral. But it's just sort of that, that's the assumption that they made going in, and that's what they were trying to argue. But I think you're exactly right that to rule out I mean, certainly I would argue anyway, is that if you're getting a much more widespread pain, you have to be engaging additional circuits than just a trigeminal to caudalis kind of a circuit, right?
Right, I agree with you, but your first question was, in my opinion, far more relevant. Talking about intensity in terms of what they were evaluating, because we know that there is an increase, a step increase, if the attacks, just talking about the attacks duration, it's extended, the game is going to be extended, the wing up is going to be bigger, and we are going to have a major problem. Now, in terms of what they are trying to do, or trying to get, in my opinion, an over interpretation, is then they are measuring, if I understood that correctly on the scale, they were using 1 kilogram force. Rhayane, that's correct. That is an awful lot. I mean, just talking about the level of sensitization of an nociceptor, we are talking about a 90 degrees kilogram. So,
yeah, but it's going to be a force per unit area, and the pressure algometer is relatively large, blunt.
I do believe that is the case, but when I saw the number, I was just like, Jesus, what they are using? Hammer. But obviously, there is other consideration with the with the symptomatology. With, for example, functional pain evoke. There is actually bruising trigger points. They try lidocaine, for example, to try to block the peripheral inputs. That kind of proof of concept, and do we in fact have a trigger, and we have in reality we have a contribution within the central nervous system. But as I said before, we do not have the slightest idea of how the brain stem will be integrating three branches that more likely will be acting one against the other, overlapping dermatomes with the release of CGRP and bradykinin is going to be affecting that. And I agree with you, that's going to be a transient change. There must be something else happening that is going to activate the circuit. But in terms of this manuscript in particular, I don't see how the case that there is a more contribution of the peripheral system over the central system can be defended.
Right. Yeah. I mean, the local anesthetic experiment that you're suggesting would be ideal. The problem then becomes, though, is it a sort of a muscle drive, ligament drive, or really drive in the joint itself? And so then it becomes a question of, how much local anesthetic do you have to infuse to basically take out the peripheral drive?
Exactly. You need a distance, a minimal distance, or at least we know that B2 and B3 is going to be overlapping. So that doesn't resolve the problem. It's going to be more like B1 versus B3 to try to make the case that, in fact, a point in B1 can be controlled as a trigger point if you want really spatial discrimination.
Yeah. Well, I think they were limited a little bit to the extent of the data set they were accessing, right? I mean, there's a cross-sectional study that was sort of had what it had. Yes. And so going back to do those kind of additional V1, V2, V3 sensitivity that you're suggesting, I think would have been ideal. They just didn't have it in the data set.
Right. Thank you, Rhayane. Well, it's very interesting. I'm definitely going to need to read this paper.
Sorry to take over there, Rhayane. Very, very nice presentation. Very interesting paper.
It was.
Thank you.
Any other questions? I saw a hand raised for just a split second. So I want to open the floor. Or comments, thoughts.
Hi, very quickly, just I appreciate the discussion, appreciate the paper. I think it was very insightful to have both. And I just wanted to briefly mention if it was possible that thalamic connections might explain why they were looking at different places. Also, one of the questions was regarding the sympathetic nervous system. Hypothalamic integration, I think, would have been one of those places in the brain that I would expect increase. So a general increase in sympathetic drive can affect both dermatomes, even if they are not in the same place. But I just wanted to mention those two places in the brain that I personally find interesting and might be one of those substrates that explain these interactions. Thank you.
Rhayane, any thoughts on this?
Okay. Interesting point of view. I agree for you. And I think a difficult point in the aspects in different patients. In these papers, the departments with the same diagnosis. And repeat, please, the question. Sorry.
It was not a question. It was more like a comment.
Okay.
I was trying to like integrate what was said in the conversation, but
thank you.
yeah.
Sorry.
No worries.
It's exciting. I mean, I think these are exciting directions that maybe they're also thinking is like intervention studies or MRIs to see what else is different. All right. If there's no other further comments or questions, thank you all for attending and the lively discussion. I think it makes these things so much fun. So thank you for contributing. And with that, look out for our next events coming up, webinars and journal clubs. And thank you for joining. Thank you so much, Rhayane, for presenting. Really great job.
Thank you. Bye-bye.
Good points. Excellent.